Okay, it's 3 o'clock. So, John, should we say welcome to everybody?
Yeah, okay.
Yes.
So welcome everyone to this webinar of GPCC entitled Person-Centered Care Arena Webinar and Multi-Stakeholder Partnerships. Let me introduce myself, John Chaplin at the bottom there, and your co-host today is Annika Lindström. The people you see on the top row are the presenters today, and each of those will present themselves at the time when they give their talk. Move on just a little, we keep it very short, the introduction. So housekeeping notes, if you could please put your questions in the chat during the presentations, then we can read those as they come along and present those after each talk. Please stay on mute if you're not asking a question. And the webinar will be recorded and put onto YouTube later. Let's see, what I also wanted to remind you of was the conference, the GPCC Global Conference on Person-Centered Care, which will take place next year, the 13th to 16th of May, here in Gothenburg. The abstracts are now open, abstract submission is now open, so please consider coming to the conference. The other thing I wanted to highlight was today we're celebrating the What Matters to You Day, which is an international day. It was started in 2014, an initiative from Norway, and the aim is to encourage and support more meaningful conversations between people who provide health and social care and people and families and carers who receive health and care. And if you wish to participate in that day, then there is a hashtag here, WMTY, in order to participate. And with that, then I think we can move on to the agenda for today. So we have 4 presentations. Each presentation will be 10 minutes, followed by a 5-minute opportunity to ask questions. And then at the end, we will have a 20-25 minutes question and answer discussion for everyone. And with that, then I think I can move on to ask Jana to present the first presentation. I'll stop sharing.
Right. We can also add before Jana starts that when it comes to recording, we'll just record the person who is talking in the presentation. We won't be recording the participants, so you know that.
Okay.
Okay, Jana, go ahead.
Yeah, and also to briefly introduce myself, I'm a person with at least 3 hats on, actually. I'm a patient with a rare disease. I'm co-leading a patient organization, so sometimes I'm a patient representative, but today I'm here as a patient co-researcher who is employed by the Center for Person-Centered Care at Gothenburg University. And I'm very happy to be presenting the preliminary results of our systematic mapping review of systematic reviews on patient and public involvement in healthcare. And part of our research team are also Jose Santana, who's here today, and Ida Björkman, who's also here today. So the motivation for this study was that we see that there is an increase in policies requiring patient and public involvement. But the vast amount of literature makes it very difficult to know which approaches and methods for patient and public involvement, PPI, work best. And especially when you are a stakeholder who's really just at the beginning of the journey of trying to involve patients and caregivers and the public into their work, then it's really difficult to know how to do it in a meaningful way. When we first started studying the literature, we realized that PPI in research is actually quite well studied, For example, we would like to highlight an article, a systematic review by Greenhalgh et al., where they looked at conceptual frameworks for PPI in research and also give tips on how to adapt frameworks to specific needs for PPI in research. But then we couldn't find a similar study for PPI in healthcare practice, and that's our interest. We wanted to know, how is PPI done in healthcare practice with the focus not just on own care and self-care and participation in self-care, because that is also something that has been studied quite well, but with the focus on own and others' care to improve healthcare systems. So we decided to use a technique called the mapping review of systematic reviews. And we are doing this with the goal to provide a broad overview about how patient and public involvement has been conceptualized and conducted and measured in healthcare practice. So we started with 5 research questions, and since we don't have so much time, I'll only be talking about 3 of them today. If you want to follow up on our work, I have put here the registration number at the Open Science Forum. So when the mapping review is being published, you can check there where to find the publication. So the research questions I'm going to be talking about today are: in which contexts is patient and public involvement conducted in healthcare practice? Which conceptual frameworks and terms have been used, and which research gaps can be identified? So we did searched 3 databases, PubMed, PsycInfo, and CINAHL, from 2001, and we did our first search in December 2021 and updated the search December last year. We screened a total of 4,419 records and decided to look at the full text of 108 articles, and ended up including 37 systematic reviews in our mapping review. So when it comes to the contexts we have found where patient and public involvement is being conducted in healthcare, then it mostly comes to healthcare quality improvement, patient safety, community-based initiatives, peer support, and patient and public involvement in the education of healthcare staff. So for healthcare quality improvement, patient safety, and education of healthcare professionals, it's very general and in various settings and various diseases. But when it comes to community-based initiatives, we see that this happens mostly in low and middle income countries, especially for infectious disease control, but also for child and women's health. And when we look at peer support, then that's mostly done for mental health and substance abuse. So when it comes to terminology, we have many terms with a very similar meaning. And we think that leads to problems in reviewing the literature. And also we think it leads to problems in practice. Because what happens is that it's mostly a combination of terms that is being used to describe patient and public involvement. And that is one of the term combinations, of course. And it's mostly who is being involved and how are they being involved. So you can basically combine any of the terms on the left side with many of the terms on the right side. And I'm not even listing all the terms that are out there. These are just the terms that are occurring in our 37 systematic reviews. And then there are some authors that have decided that maybe we want to avoid this messiness, and rather talk about participatory approaches or participatory methods. And when we look at the number of terms that are being used in the 37 systematic reviews, we found that there are 30 different combinations of terms. And I just wanted to point it out that when we might be thinking that it's smart to just use participatory approaches or participatory methods to avoid the messiness of the terms, but then that's maybe too general, because when you then search for literature, for example, you find also how involvement and participatory methods are used in other settings than healthcare. So that also leads to problems, and we don't have a solution to offer. It's just a general problem in the field that the community needs to form consensus around. When it comes to conceptual frameworks, first of all, maybe there are some of you in the audience who are not researchers and don't really know what we mean with a conceptual framework. It's usually used to organize ideas and make conceptual distinctions. It should be easy to remember and easy to apply. And it should also illustrate the expected relationship between cause and effect. So I'm giving you here a very famous framework, which is cited more than 10,000 times in the literature. And that's Arnstein's ladder of citizen participation. And you can see that there are 8 levels of participation, and the highest level is citizen control. So this framework would probably indicate that citizen control should be best, but then there's not enough evidence that that actually is the case. So there is also some criticism about Arnstein's ladder, also because it's quite power focused. And you can see that some of the stages, they're degrees of tokenism, and I think Maria will be talking more about those, about tokenism in the very last talk of this webinar. So I will not talk too much about it here. I just wanted to tell you that in our 37 systematic reviews, there are 28 which have mentioned frameworks, but only 13 reviews have actually applied a framework to analyze and discuss their results. Then we see that many of these frameworks are quite similar. At the same time, they use a bit different terms, which then again leads to this messiness of terms, and some of the frameworks appear to be context independent, like the Arnstein's ladder, and then they occur in more than one context. And when we look back to the context that we have identified, we can see that there are quite a lot of frameworks, and of course, most of them are in the healthcare quality improvement category. When it comes to research gaps, we can see that there's a need for studies with consistency in terminology and reporting. So not just the terms that are being used, but also how you report on patient and public involvement when you have done it. And then there's a need for more robust evaluations for measuring long-term outcomes and cost effectiveness. So with that, I want to give you the take-home message that this mapping review will hopefully direct readers to guidance documents and conceptual frameworks that will be helpful for the implementation of patient and public involvement in various contexts and settings in healthcare practice. And when I look at my time, how am I doing with my time? I'm giving you the references that I've cited in case you want to take a screenshot. Because if I have time,
you have time.
Then I actually have a few points from my very own patient perspective. It's been 45 years since the Alma Ata came out, and the Alma Ata says, the people have the right and duty to participate individually and collectively in the planning and implementation of their healthcare. And I'm 45 years old, so I'm standing here 45 years later, and I'm surprised and sad to see that there's very little consensus regarding the use of terms, regarding the reporting on patient and public involvement, and also regarding the use of frameworks and guidance to implement PPI. And if I can suggest something, I would actually like to move away from hierarchical and power-focused viewpoints and rather want to create shared visions, goals, and roles together with researchers and with healthcare practitioners. So that can be applied in both research and healthcare practice context. And for me, even consultation can be meaningful in certain contexts, especially if the stakeholders report back to the patient involved how their advice has influenced the decision-making process. Then I think that consultation, even though it's lower on the ladder, on Arnstein's ladder, it can be meaningful. And I think we should start seeing patients as persons with capabilities and vulnerabilities that can also vary over time. So there needs to be flexibility when you want to involve patients, because sometimes patients are not doing so well. And then you also need to be flexible to work with that. So now I can stop sharing my screen, maybe, so I can see if there's any questions in the chat.
Oh, thank you. Thank you, don't see at the moment any questions in chat, but maybe they're coming a bit later, or maybe people would just like to raise a hand, and then we could answer the questions in person. We've got sort of 9 minutes or so for questions for this paper. Maybe I could just start. When you see those ladders and in various areas of research, they've got a kind of a ladder of categories. It's always tempting to think that you sort of start at the bottom and start to work up the ladder. And I was just wondering whether there were any examples that you'd come across in the systematic reviews of where a project had started at the lower end of the ladder and then sort of there's evidence that it had moved to a greater amount of patient involvement, or moved up the ladder. Is that something that happens, or?
Well, we looked at systematic reviews. So these systematic reviews have included very many studies, single studies, that that in the systematic reviews we don't really see that. I mean, we've seen some systematic reviews where there was patient involved in writing the systematic reviews, but it's very few of them. And then that's research again, it's not healthcare. So I'm sorry that I can't point to any examples, but if someone knows an example where that was the case, I'd love to hear about it.
We can also add, if we have Swedish audience and you feel comfortable writing your question in English, you can always write it in Swedish and me and John can translate it. So you don't have to write. Oh, there we go.
Have you found terms in your overview that you prefer? It's hard. I mean, even patient and public involvement is difficult, even though we are using that now through the review, but it doesn't really include the caregivers, because caregivers may have sometimes different perspectives from the patients and from the public. So even that term that is so coined now, patient and public involvement, or PPI, because it's so nice and short, even that term is a bit difficult. I mean, sometimes it's patient and family involvement, but family involvement is also difficult because sometimes the caregivers are informal caregivers and they're not family. So how do you include them? So I think it's very basic conversation that the community needs to have, like how do we actually want to call this activity in healthcare? Because I also think it's different. The different contexts, patient and public involvement can happen in so many various contexts, so that I would rather really like to divide between healthcare practice and research, because that is also sometimes mixed. But yeah, no, I don't have a favorite term, and I'm sorry I can't say that yet. I think the community needs to co-create and co-design the terms.
I can ask another question, talking about favorites. I just wondered whether there was any paper that you came across which gave a very good example of PPI that you would recommend that we read.
Yes, there is a paper. I can put the link in the chat in the next talk by Bombard et al., which is really good because they give a table, I think it's table 2 in the paper, where they talk about challenges and lessons learned, especially for healthcare practice. So that one is a really good one to go to. Okay. I put a link to it in the chat.
Okay, thank you. We've reached the end of this question and answer phase. So I'll hand it over to Annika to introduce the next speaker.
Yes, and we're going to be listening to Kiana.
Yeah.
So I'll hand it over to you, Kiana.
Yeah, thank you very much. I'm going to share my PowerPoint. Let's see. Is it in display mode?
Yes.
Yeah, thank you very much. Yeah, to tell you a little bit about myself, I'm registered nurse, and my clinical experience is from nephrology with 20 years in dialysis, and I have been working at Gothenburg University since 2016 with the nursing program, and as of April this year, I am a PhD student in the project related to EUPATI. And I will start the presentation by giving you a very short and general description of EUPATI and EUPATI Sweden, and focus on the PhD project that I'm involved in. The European Patient Academy on Therapeutic Innovation, EUPATI, is a flagship project of the Innovative Medicine Initiative, and was launched in February 2012 as an initiative from European Patient Forum, EPF, and European Federation of Pharmaceutical Industries and Association, EPIA. And the aim was to rethink the way patients and public understand the medicine development process and their own involvement within this process. The basic idea is that, armed with a deeper understanding, patient, experts, and advocates are empowered to work effectively with the relevant authorities, healthcare professionals, and industry to influence the medicine development process for the benefit of patients, of course. And the main objective of this project were to develop and provide an accessible, well-structured, comprehensive, and scientifically reliable, and also user-friendly educational material for patients on the process of medicine research and development, and also to increase the capacity for patient experts and well-informed patients in patient organization, and to be effective advocates and advisors in medicine research and development. And as a third goal was to empower patients to provide appropriate patient-relevant advice and insight to industry, academia, establishment, and ethics committee, among other groups. EUPATI was founded from the beginning founded by the EU, but is today run by a foundation, and the national EUPATI organization has been formed. In total, there are 23 national platforms of EUPATI. And in Sweden, EUPATI is run by Disability Rights Federation with help from Swedish Inheritance Fund. And Disability Rights Federation is an umbrella organization that consists of 50 patient and disability rights member organizations. If you look at the international EUPATI course online, its toolbox is organized in two main areas. They are focused on medicine research and development and patient engagement. And the Swedish version has been adopted, and it consists of 4 different courses. And as you can see on the slides, the course 1 is focused on the introduction of different subjects. Course 2 is focused on research and development, and course 3 is about improvement and permission of medicines and medical technology. And the last course is focused on patient involvement and topic related to that subject. And each course includes lecture by experts, learning objectives, and reflective questions related to the course content, and also an evaluation of every step in the online course. And now I would like to take a few minutes to present the PhD project associated with EUPATI in Sweden. And this project is a focus on the project focus is on conducting an exploratory multi-stakeholder analysis. And the overall aim of this PhD project is to examine and describe the implementation of EUPATI Sweden through 4 different studies. Since the project involves multiple stakeholders, representatives from various sectors such as industry, academia, patient organization, and regulatory agencies are included in different capacity across these 4 studies. If you look at the study number 1, the first study aims to investigate the perspective of patient representative regarding patient participation and their experience of collaborating with other stakeholders. We are using a survey and we are using a survey that was translated and an adopted version of the questionnaire that has been developed in Belgium. And we're also using semi-structured interview as a method. And we have some data has been already collected, and we are continuing with the data collection during this month. And the interview questions, to give you an idea what are about, they focus on understanding how patient representative from their perspective define patient involvement in medical research and how they have collaborated with other stakeholders. Also their experiences during collaboration, and also identifying factors that contribute to successful collaboration, and also recognizing any obstacles that they have encountered during their collaboration with other stakeholders. The second study aims to describe the viewpoints of different stakeholders regarding the barriers and facilitators of patient involvement in medical research and development. We plan to conduct a semi-structured interviews with participants from EUPATI Sweden online course, and the goal is to interview 5 to 6 participants from each stakeholder group, and we hope that we can gather between 2 and 25 participants. The study 3 is directly linked to the EUPATI Sweden online course and aims to explore and describe its launch. And to achieve this, we will use pre- and post-course surveys. These surveys will focus on participants' motivation, their expectation, and self-assessment of their knowledge about pharmaceutical and medical technology research and development. We will also assess how the course content aligns with participation's expectation and self-perceived knowledge level. And by comparing their knowledge before and after course, we hope that we can evaluate the impact the online course has on their the knowledge and their participation with other stakeholders. And to go to the last study, study 4 focuses on examining the potential effect of EUPATI Sweden. The goal is to describe stakeholders' experience regarding the impact of Swedish EUPATI course on patient and public involvement, PPI, in medicine research and development. The method we are using is we are going to use the same survey that we use in study 1. And send it to those who involved in creating a EUPATI Sweden platform, and also those who have participated in the course, online course. And we are going additionally add some questions that explore how EUPATI graduates engage in medicine research and development after the online course is completed, and their perceived role of EUPATI Sweden in promoting PPI, and also how the course may contribute to creating more favorable structure and conditioning for patient-centered care. And that was my little bit short presentation of the PhD project and a little bit background. And thank you very much. And we are answering questions if there is any.
Thank you, Kiana. Very good. And we have one question in the chat, and it asks, is there a link to the studies when it comes to EUPATI?
Yeah, of course. All of studies linked to EUPATI because we are interviewing and sending surveys to those who has participated in Sweden, or maybe you're meaning to international EUPATI, maybe.
No, I think it's a link to the studies. It's just so that you can,
of course. All the participants are from EUPATI online course in Sweden. Yeah.
Okay, that's good. How do we reach those links? Can we reach them through your homepage, or is there somewhere we can find them?
It's not published yet because it just started, so there's no publications yet, unfortunately.
Yeah. We are in the beginning. We are collecting data, so hopefully in the near future, the first study will be completed.
Right.
Yes.
Yeah. And now Jenny has raised her hand, so you can ask a question.
Yeah.
Yeah.
Thank you, Kiana, for such a nice presentation and such an interesting project. I was curious about the first study, and if you do have any preliminary data that you could share with us, or have you not come that far yet?
We haven't come that far yet. We have a mini study. Can I say that it a little bit done, but that I have not accessed the complete data in that. In near future, we hope.
Yeah. That's good. And since you're still working on it, but is there anything that you've been surprised that you found so far?
In those interviews that I have done with the patient representative, almost every one of them lived the difficulty to get into contact with stakeholders. At the first contact is very difficult to make. And usually those that have experience of collaborating with other stakeholders have been making contact through other contacts. So they have lived it as a problem, a reason, or the difficulty to collaborate. Yeah.
Well, that's very good. It's going to be so interesting, and I see in the chat that they're wishing you good luck.
Thank you very much.
It's very good. We still have 5 minutes. Does everybody else have a question?
I could comment on the question.
Yes.
Yeah. The preliminary findings was that it's not just about having the knowledge about how it's done, but just as Kiana said, it's also about having the networks, the social networks with other patient organizations, other patient representatives, or authorities, or industry, and so on. So it's yeah, that's a huge thing, making these connections. Yeah,
I imagine that's a huge challenge, just making the connections and also being comfortable participating.
And some of the participants have also lifted that they are being contacted a little bit late in the research process. Sometimes they feel their name has to be on the project to get finance for the project, and they are coming in late in the process.
Well, that's also an important finding, I think, and something to learn from. Yes.
Is that would you say that this is related to what we call tokenism?
Ida?
Yeah, it could be. Yeah, definitely, because they don't have the possibility to actually form the projects or the research questions and so on, but they are coming in at a late stage. Yes, and that would fall under tokenism. Yeah, definitely.
Yeah, that makes sense.
And those that are involved in high in the letter that Jana was speaking about, they are very informed patient representative, and usually they take contact by their own, or maybe they are sitting on the ethic committees and involved in research projects and in the process.
So the challenge is to find participants that aren't that high up on the ladder. Yeah, I understand. Yes, well, thank you very much. It's very interesting. So yes, and I'll hand over to you, John, so you can introduce the next speaker.
Okay, thank you very much. So our next two speakers are Jenny Milton and Elin Siira, who will present the next. And if you can share your screen. Thank you.
I hope you can see a full screen there with the presentation. Is that correct?
Yes. Yeah.
Great. Okay. Thank you for inviting us, and happy to be here to present a research project financed by Forte between the years 2023 and 2025. So the name of the project is Co-Production to Reduce Involuntary Loneliness in Swedish senior citizens. And the research group in this project consists of members from different universities and organizations. Two of us are here today to present the idea with the research project. My name is Jenny Milton. I'm a postdoc and a lecturer from the University of Gothenburg. And my colleague, Elin Siira, is a full-time postdoc from Halmstad University.
So I will start out by giving you just a brief background and rationale for the project. So first of all, there's a need for measures to prevent social isolation and involuntary loneliness among older people. We know since before that social isolation and loneliness are linked to decreased physical health and increased use of healthcare services. At the same time, national governments globally today view citizens' involvement in public services both as a means to develop more efficient and effective services, but also to build trust and satisfaction with public policies as well as public services, and also as a valuable way of handling challenges such as aging populations. So as an example, in Sweden, there are demands on social services as well as healthcare to work more preventively and health promoting, among other things, through initiatives that reduce social isolation and involuntary loneliness among older people. So while there is an expanding user involvement in social services as well as in healthcare, such are often inconsistent and the knowledge of their effect is limited. And likewise, the knowledge about the effects of various interventions to prevent and reduce social isolation and loneliness is very limited. And so is the knowledge on methods where different stakeholders work together and include older citizens in the process. So that said, the purpose of this project is to develop circular models for participation among senior citizens to co-produce welfare services together with actors in healthcare, social services, and civil society to prevent involuntary loneliness and social isolation. And to the right here, you see examples of the actors included in the project.
So the design of the project, we try to illustrate here as a circular model. The research project is based on this circular process where the data collection takes place at several levels and with different methods. So the knowledge generated is continuously integrated into the development of interventions to prevent involuntary loneliness and social isolation among senior citizens. We will conduct interviews to understand the prerequisites and context of measures to prevent social isolation and involuntary loneliness. We also plan to create learning labs that will support effective, equal, and accessible participation among senior citizens. Along with that, we also plan to develop and assess the potential of local co-production initiatives. And finally, we plan to create, test, and evaluate solutions through co-production to prevent the social isolation in the local context of a citizen panel.
Yes, so one of the first aspects of the study is interviews, and we will conduct interviews continuously throughout the project, both for understanding social isolation and involuntary loneliness among older people and how different stakeholders work with different methods to prevent this. But we will also carry out interviews to evaluate the circular model among the participants. And this will be done both through individual interviews and focus groups. And the participants in these interviews will be senior citizens and their relatives, municipal and regional actors in healthcare and social services, and actors from civil society organizations.
Yes, so with these interviews, we aim to have a better understanding of the innovative processes that engage the senior citizens. But then by having that, we would like to create these learning labs and have participating municipalities to take part in well, planned now anyway, 3 so-called learning labs, together with older citizens, relatives and representatives from regions and the civil society. The lab provides an opportunity to exchange experiences and develop proposals for new solutions for the targeted group. And while participating municipalities can then get input and evaluated recommendations on their work. Also, results from the project's various sub-studies are presented and discussed in these learning labs. The learning labs will also be a platform for researchers to collect information and for actors to get input. The participants are senior citizens and their relatives, as I said, and also then municipal and regional actors. The civil society organizations are, of course, a very interesting part in this learning lab. We mentioned in the previous model also the co-production teams, and you can see in this figure here that we're moving forward in the project with this co-production team, which is a means to put solutions into practice. This team will work actively with measures to reduce involuntary loneliness and social isolation among older citizens in their direct context. So co-production teams assemble throughout the project period and consist of municipal professionals and dedicated process managers. Part of the team will participate in learning labs, as I presented previous slide. The researchers meet with the teams 4 times, as of planned now anyway, to collect experiences and support. The participants are then the municipal professionals and process manager, as I previously said. By that, we move forward to the citizen panel.
So the Swedish Citizen Panel is a resource that we will utilize in this project, and the panel is based at the SOM Institute at Gothenburg University. The panel consists of citizens who voluntarily, on their own initiative, choose to join the panel to answer questions in surveys about 4 times a year. And these surveys are here researchers as well as different organizations can pose questions to these citizens. So through the citizen panel, we will assess the perspective of over 10,000 older people at a national level, as the member of this panel is spread out throughout Sweden. And we will use these perspectives both to understand the older citizens' experience of social isolation and involuntary loneliness, but also to assess the potential of local solutions, which we will explore in the co-production teams, to assess them on a national level or in a national context. And the participants in this part of the project are senior citizens. So that said, once again, the purpose of doing all this work is to develop circular models for participation among senior citizens to co-produce welfare services together with actors in healthcare, social services, and civil society to prevent involuntary loneliness and social isolation. And by doing this, our aim is to both explore and support the potential of local co-production initiatives to prevent social isolation and involuntary loneliness, but also to critically examine the potential of using this national citizen panel as a means for effective, flexible, and accessible participation of older adults in the co-production of welfare services. And we also finally wish to stimulate generic methods for co-production of elder care services that includes all these mentioned actors.
I mentioned in the beginning that we were different organizations and universities represented in the research group. And here you can see a list. We also have a user and public involvement expert in the group. We would like to welcome you with questions and reflections, and if not here today, then you're welcome to contact us at a later point. So by that, I will stop share and see if you have any direct questions for us now. Thank you.
Okay, thank you, Jenny and Elin, for a very interesting talk. So this talk is now open for questions. I don't see any questions in the chat at the moment. Maybe I could just start off with, oh, sorry, there, Edith has her hand up. Oh, it's Edith.
Thank you. It sounds like it's like a built-in implementation process. Is that so in the learning labs or the co-production teams? Is it a way to also implement the possible solutions?
Yeah. Would you like to answer, Jenny?
So I can try to, and you're welcome to fill in, Elin. So we are focusing on the method, the circular process, and by doing so, we want to inject findings from interviews from the citizen panel, inject what we find in the co-production teams up to the learning labs, because there will be less meetings for the learning labs than it will be for the co-production teams, and also aiming for the municipalities, the partaking municipalities, to work further with these co-production teams, so maybe they can still be alive after this project ends. So it's we hope to implement from a research point of view, but also have this as an idea for and a support for the municipalities to be able to continue working with this and find out themselves that this is a way forward. Elin, would you like to fill in there?
No, maybe I could just fill in that we have an ambition with this project to not only develop, how would you call it, a kind of abstract model for how to go about things, but we also wish to actually make change in practice, and therefore these co-production teams are really important, because throughout the project they will work with the knowledge that we gain, and they will work with these in practical situations in the municipalities to actually create some type of change or implementations of this knowledge. So yeah.
I see we have 2 questions in the chat. Elin, maybe you would like to answer the first one too. I'll read it out loud. Senior citizen is a very wide age group with different needs and expectations. How will you handle that? I think, Elin, you're the expert in this area.
So the purpose of the project is to develop methods to prevent social isolation and involuntary loneliness. So the target group is older adults that experience these types of phenomena. But we also have an ambition in this project to involve older adults in the co-production of welfare services. So I would say, at least from my perspective, in this project, we involve different types of groups of senior citizens, so to speak. And we have no, yeah, I just agree with the question. It's a wide group and there is heterogeneity in this group, and there's no, we have no ambition to, we don't think of senior citizens as a group with, they may have some shared interest and some shared experience, as do we all in all age groups, but not more than any other age group.
And sorry, Elin.
Oh, I will read the next question and pass it on to you maybe. How open are the co-production teams? Can interested people join anytime? Jana asked.
Interesting question. And we are very open to have interested people joining in the co-production teams. However, we have now, this project is very young, as you could see, it started this year and only a couple of months back. So what we've done now is to recruit, so to speak, municipalities to take part in this project. So our one member of the research team, Teresa Larsson from the Gothenburg region, she has sent out a flyer, basically an invitation to all municipalities to be able to take part and show their interest in this project, but also then be willing to dedicate a process leader for all these activities that we will make for the Learning Lab and co-production team. So the municipality in itself will recruit members to these co-production teams and represent the Learning Labs. So it's part of the method development is to see what people engage and get invited to these co-production teams, then that the municipality in itself see as important.
Okay, thank you. I think we have to move on to the next speaker. Thank you very much.
Thank you.
And I'll pass it over to Annika.
Yes, thank you. And it's time for our last speaker, and that is Maria who's going to talk. So welcome, Maria. And you need to turn on your microphone. Yes, she's looking for the. Yes.
Okay, I'm on mute now.
You're okay.
Can you see my slides?
No, not yet.
No?
No.
Okay.
So.
Yeah, sure.
Yep. There we go.
Yeah, now we put it on presenter mode. Yeah.
Perfect.
Well, thank you for the invitation. I'm glad to be here and learning from all of you. This is fantastic. I'm Maria Santana. I'm at the University of Calgary. I'm an associate professor, also the director of the Person-Centered Care Research Team there at the back. I'm an advisor for the Gothenburg Person-Centered Care team. So working with all of you is a pleasure. And at the national level, we do have a national initiative to engage patients and public in health research. And I'm the provincial director of the patient engagement team for this initiative. So a little bit about the initiative that was launched in 2014 by the Canadian Institute for Health Research, which is the major funding agency for health research in Canada. And the initiative covers 11 provinces and territories in Canada. And how this is structured, and of course I can talk for hours about it, but try to be brief, this really depict the vision and the mission of this national initiative, which you see that it represents 4 different teams. So the patient engagement that I lead here with the objective of engaging patients and public as active partners throughout the research process. We do develop capacity. So we have different courses, and I will touch on one specifically. And then what we do is that try to apply all the knowledge that we acquire through working with patients and their communities, developing these training modules and all the learnings through the health system to make a more focus around the priorities, what is important to patients. And then it really also the data team and services, what they do is that enable equitable access to data to improve health research. The vision really is that the health outcomes, by doing all of this, the health outcomes will be improved for all. So, okay, sorry. So this is in terms of capacity development, my team and my team, we have the Patient and Community Engagement Research, PACE program, which is a year of training program. And we have trained over 100 graduates to date. It provides training on participatory health research methods, produces patient-led peer-to-peer research evidence, and has contributed to science and practice of patient and community engagement in research. We have 15 peer-reviewed publications that is led by the patient trainees. And we do have all the other reports available on their website. So more information on the website if people are interested. We do have testimonial with, from patients that they've been trained and patients that they have a wide experience in partnering with us in health research. And why do we do that? I mean, why SPOR is the national initiative, supports, engaging. Why do we do that? And so in this table, I try to encapsulate the potential benefits for health research and for the patients. And so what we have learned so far is that when we engage public and patients in health research, it improves the quality and overall the effectiveness of the research. And from the patient perspective, it really improved patient outcomes. We just conduct, last year or so, published a scope and review, and we saw that 5% of the studies provided evidence on improvement on patient outcomes when you partner with patients in health research, and also improve quality of healthcare. And this quality of healthcare leads to, I'm going first to touch on what Jana and others have, and Kiana touched on aspect of how do you do that, and how do you, is it a framework that can guide how do you engage meaningfully? And this paper was written with our patient partners, where they identify the priorities. And really what the paper said is, hey, if you would like to engage meaningfully with patients as partners in your health research project and build that partnership, these are 4 guiding principles that you need to consider. And so under inclusiveness, try to be diverse. And diversity has different aspects. So you can look at diversity from different point of views, not only different cultures or ethnic backgrounds, but also different degrees of chronicity with the diseases, or different experiences as a patient partner. Support, I think one of you touched on support, and so tailor the support. Everybody is a bit different. Ask them, do they need to be compensated for their time? How this might look like. Build a very respectful collaboration. Make sure that the roles and responsibilities of everybody in the team are clear, that the communication channels are very well spelled out and people are at the same level. And all of that really takes you to building and sustaining relationships, walking away from tokenistic approaches that I think Kiana mentioned, and Jana as well, and evaluate. One of you talk also about feeding back the result, be respectful and let them know where you are at. Don't bring them at any point on their research just to add their name to the project and then walk away from it. But in terms of this is how, and I would like to just to show you an example very briefly, because this is a work that we've been doing since 2017, and we will have the pleasure to collaborate with Gothenburg, and one of you was part of the process. And it was funded by our Canadian funding, CIHR, that I mentioned before. And what we did was to work with people, asking them what matters to you in terms of quality improvement. What are the pieces that you would like to see improved at the level of healthcare system? And so we develop metrics that we call the person-centered quality indicators. And so in a nutshell, the first phase was very evidence-based. So we went to the literature, published and unpublished, looking for measures. How person-centered care has been measured? What are the metrics? We conducted an environmental scan, national and international audit on the indicators used, how these measures have been used and for what. And of course, from the very beginning, we have engagement and partnership with patients. And the next point was to go out there and partner with organizations and communities. And I'm going to be talking about this a little bit more in detail, because it really was asking them what matters to you. And then, of course, we partner with our quality improvement leads and the healthcare providers and the healthcare system. So let me just explain to you a little bit. Look, if you want to know more about this phase, we have publications for each of the points. And this is what I would like to focus on. And this is really asking that question, what matters to public and patients in terms of quality improvement? And because going back to the diversity aspect on how do we engage patients and public to make it diverse and make sure that we were bringing the voices of different communities. We work with community brokers. And who are they? These are leaders with their community, that they go into their community and work with us to get the information. So we don't speak Arabic. So we work with the Syrian community, and the broker was Syrian, and he ran focus groups with their community in Arabic. And, you know, exactly the same with the Spanish, Latino community here, and so on and so forth. So we had 6 different connectors with the most common immigrant newcomers communities in our province. That is a bit over 4 million people. And also, we capitalize on the panel of patient advisors that we have within our healthcare system and work with them. And what did we learn from them? So we learned what were important to them. And I'm going just to highlight 3 of the main priorities. Communication. How can we enhance and promote communication? Communication to access care, maintain care, engaging. Talk to me, engage to me, explain to me. Let's share the decision. Let's you know, I have different needs, tailor to my needs. Talk to me about this shared decision making. What is important to me, to my family, to my context. Transitions of care, really interesting data coming from young adults that were transitioning from pediatric to adult care. And they found it like one of the most difficult stages in their life, this transition.
Maria, oh, sorry, go ahead.
Yeah, I'll wrap it up yeah. And so then we collected all this wisdom, all this data, and brought a panel of national, international collaborators, our patient partners, community partners, quality improvement leaders, government. We had our collaborator for the GPCC there as well. And what did we do is that from the amount of indicators that we have identified, we reduced it to 26. And this paper describes how was the process. This is just to give you an idea of the indicators that they were classified by the Donovidian framework, structure, process, and outcomes. And this is how the indicators look like. If any of you is interested, we do have the indicators available on our website just behind me. And they also ask, and Jana talk on and describe really well a conceptual framework. So how do we use this, right? And can you guide us? So how do we practice that? And so we develop the framework. And basically, I just want to wrap up talking about the impact and the take-home message. So the impact at the provincial level is that what matters to the people has been incorporated into health initiatives. For example, patients' navigation through the healthcare system. That these indicators that we develop are going through implementation in primary care. This is our next phase, and the objective is to optimize primary care from the patient and public community perspective. And we have informed provincial health policy. If I need to give a message rounding up, this is just the patients and the community perspective, their experience, their learning, it plays an important role in ensuring that research is relevant and reflects what matters to them, to most people. And that to guide healthcare policy and practice change, that transformation in healthcare system that we're talking about, we do really need to develop and implement efficient ongoing mechanism to measure and evaluate quality, health quality that incorporates the patient perspectives. So I would like to wrap up here and thanks my team, the founders, and all of you for being here. Thank you.
Thank you, Maria. Very interesting and inspirational. So I'm thinking we can have 5 minutes for questions for Maria, and then we'll open up for a more general discussion when it comes to what we've been listening to this past hour. So is there a question for Maria? You can raise your hands or write in the chat. And while we wait for that, I can ask a question, because I was wondering, I think it's very inspirational, but I'm also thinking about how did you manage to gain the trust so that you get this involvement and get the answers that you needed?
Yeah, this is a really good question, Annika. Thank you. We had the community brokers. So we connected with the community brokers. Who are the brokers? Are leaders with their community. So they have the trust of their community. And so they introduce us into their community, took us by the hand, took us, and that's how, another important thing, it was that we went to their community centers. We didn't bring them to the university or to the hospital. We went to their places, and all the focus groups were done in their original language. So I could understand as far as the Spanish, the Latino groups, but the other ones were in Mandarin and Cantonese, in Talago, so but we were sitting there.
Very
so,
good.
Yeah, and it was interesting because for some communities it's really important. Food is very important, and I can relate to that as well from my Spanish background. And so it was good because we walk into the community center. Sometimes it was in a large house that one of them had. There was food, and we talk, and that was that trust that you built. Yeah, but I think the main point was the brokers, the role of the brokers.
Yeah, that sounds really good, because I'm thinking about where do we have bridges like the brokers to gain the trust and also to get the information.
Yeah,
because that usually takes time.
Yeah.
Very good. Do we have anybody else? No? John?
Yeah, I could ask a question. I mean, just related to that, really. I was just wondering whether you felt that you've developed a model that can be transferred to other countries, or is Calgary or Canada sort of a special case? You do a lot in this area, and sort of it stands out very much that Canada is sort of at the forefront of this BPI. Do you think it's a model that can be translated into other countries, other cultures?
I think so. I mean, like it's very context specific, right? Because it's been developed with people in Canada, but because Canada is a country of many cultures and many people, I think that to a certain degree it could be translated. Yeah, for sure.
Mm-hmm.
Yes, it's very inspirational. That's what I'm thinking.
Yeah.
I think it's really about finding those brokers or those bridges so that you can, yes, it's very good. We are thinking that we should have like 20 minutes of a general discussion when it comes to what we've been talking about today. So, John, it's free word, right?
Yeah, we can go straight into that. If anybody has any questions to any of the previous speakers, or would like to take up some aspect of similarities between the speakers or whatever, then we're very open to discussion. I think it'd be interesting to hear what the speakers think of the other talks.
Yes, yes, Maria.
I'm very interested in learning about EUPATI. Yeah. And I'm really impressed with, the courses, like how, the different level of training. And as we develop capacity in engaging patients and public in health research specifically, I'm talking about health research specifically, I'd like to know has it been any evaluation of EUPATI, or is Kiana, are you going to be leading that part of the evaluation? How did you also get to work closely with pharmaceutical companies?
I think Elizabeth is best can answer the question, because you are very involved in creating the EUPATI in Sweden. I leave the answer to you.
Yes, I'm involved with the Swedish national platform of the EUPATI training, and as Kiana mentioned earlier, there's a EUPATI training on the EU level, and I'm part of the European cohort 5. We graduated in October in Madrid, and we were over 40 people from all over the world, even a woman from Australia, one from the United States, and there's even a national platform in Japan. So well, there's the international training in English, and also 23 national platforms all over Europe and in Japan. And the Swedish one is quite new. We had one first course with about 30 participants, a small group that has been doing the course, and we're just evaluating their responses right now. Very interesting to see. And we chose 30 people from all over Sweden, different ages, men and women, different diagnoses. So it's very interesting. But as you mentioned, Kiana, we're trying to establish some kind of matchmaking service, because it's hard for researchers to find patients, and it's hard for patients to find the researchers. And patients are often involved in different kind of different kind of studies, but this is on another level that we want to establish the contract. So we're just in the beginning, but we want to change the world, I think. Well, the sky's the limit.
Yes. There is a question, I think, in the chat, and I think it's for you, Maria. And it's Jenny, and she's wondering, do you see any challenges when it comes to turning to individuals versus organizations that represents a lot of individuals when it comes to contacting them for the work?
Oh, yeah. So we identify this challenge. So how do we approach people, right? Is it through their organization? I mean, like this project specifically talks about the broker, but we do have projects that need very specific cohort of people, you know, and so how do we do that? We created a provincial network that is called Albertans for Health Research.ca, and the provincial network, what allow us is, what is the provincial network? So it has two components. One is a component of organizations. Within the organizations, we have even municipalities that they have some research programs, and, you know, community programs. We have NGOs,
right?
You know, NGOs that support, for example, immigration, or that support people that live in the streets, you know, that type of NGOs, and we have the support of the healthcare systems to reach out to clinics and centers that they have in rural and remote areas. In the province that I live in Alberta, around 14% of the population lives in remote areas. So it's really difficult to, you know, just to get them on board. And so developing that connections and that partnerships facilitates that. It doesn't ensure that you will get these people on board, but it really facilitated. Yeah, and then we have posting to invite people with specific characteristics to partner with us. I don't know if I answered the question right. Does that make sense?
Answer. And I think the questioner is really, that's what I'm thinking. It is hard to get both to put the value when it comes to the information that you get from one person versus a person representing an organization, but also at what level they will give you information. So I think it was a good answer, and it is a challenge, I think.
It is a challenge.
Yes. And Elizabeth has also written in the chat that when it comes to EUPATI, she would recommend the Irish National Platform, where they have a well-established network. And in Italy, they also are very successful, and they intend to be successful, but they're just starting. So she's giving them, but I'm sure you will be very successful. So
can I ask a question to Maria? Yeah, thank you very much. Maria, I think about the cultural differences between the groups as they see to be patient and healthcare very different. Have you seen some of the differences and how it's impacted on the project you have implemented?
Good question, Kiana. So what kind of differences are you referring to?
My background is from Persia, and sometimes when you contact with healthcare, you leave all the decision to the healthcare system, and for patients, usually they don't want to be involved. Sometimes, and maybe it differs from time to time, but as I experienced it as a child in Iran, that is usually you trust fully to doctors and nurses and sit back and just receive. So it's the very difficult transition to be involved and to be involved in all the process.
Yeah,
I think
I now yes, thank you for the clarification. Yes, absolutely right. Like when and so what Annika referred to, building that trust, right? For them to open up and talk to you about it. I think the healthcare system doesn't allow us for that time. It's all very bang, bang, bang. You have 5 minutes for the consultation or 10 minutes, like I think it's an average of 7 minutes that the doctor spend with a patient in a hospital unit. So, it's very like a production line, right? Like, and so, so the paternalistic approach to medicine hasn't allowed us to ask questions and build that relationship. And so in many cultures, that's still the case. And when we work, for example, with some of the communities, some of the differences, I can say that we're like, oh no, I'm not going to question my doctor. The doctor knows better. Okay, yeah, but what do you think that is important to you? So these points were brought up during the focus groups consultation with some communities more than other. Another communities, for example, at the micro level of interaction, the women didn't speak, the men didn't. And so that's another difference. How do you build that trust, that relationship that you can bring them in and work with them meaningfully is a big barrier. I think, again, having someone that was the leader of their community and allow us to do that. I mean, like, and the fact that, for example, with the white settler community, we had good connections and already developed relationship, was much easier to get what was important to them, what matters to them.
Yeah, thank you. Very interesting.
Can I also comment on that?
Really?
Because what we've also seen in our mapping review is that patient and public involvement is really implemented in the most democratic countries, right? And then, of course, in low and middle income countries where you need voluntary workers to help improve health outcomes. So it really comes down to, why do we need patient and public involvement in healthcare and in research? The most obvious reason is for democratic reasons, right? So in countries or cultures that are not so democratic, it's very, very difficult to invoke such change, to also think in terms of involvement. The patriarchy is not going to really fight itself, right? If you want to put it that way. Then other reasons, of course, are ethical reasons. It's a combination of ethical principles, right, that sort of are the reason why we need patient and public involvement. Of course, you want to improve the healthcare system and the research, but then there's also another reason, which I find quite interesting, is if you feel disempowered, if you feel like you're not able to contribute and not being involved, that also leads to more chronic stress. It's a chronic stressor to not feel involved. So by involving patients, caregivers, and the public, we decrease this chronic stress of feeling disempowered. And that will also hopefully lead to better health outcomes.
That's very interesting, Jana, because that is what I've been thinking, that the main goal is for people to get better care and to get better health. So yes, that's very good. I also want to highlight that Elizabeth writes that when it comes to EUPATI again, in Sweden, they've collaborated with all the different perspectives, the industry, not different companies, but the trade associations, academia, and authorities. So that's very good to know.
Thank you for sharing.
Could I ask a question to Jenny and Elin? I was very intrigued by the learning labs idea, but I'm still not exactly clear how they work. Are they like a laboratory, a physical place where people go to, or is this online, or how does a learning lab, what does it look like?
Well, we wish we could tell you exactly how we will do it, or if we had done it already, because the first one is due in November. So we are forming our idea and trying to put our thoughts into practice. But the idea is to then get representatives, these process leaders from the recruited municipalities, to represent their municipality and also their co-production team in a learning lab, together with us, the researchers, and also, and the representatives are then represented from municipalities, the region, and civil society, but also patients and older citizens and their relatives. So let's say, only to get an idea of how big these are, we expect the number of members in the learning lab to be about maybe 20 people. And most ideally, or our thought about how to do it is to have it in person, like in a sit-in event that preferably would happen for half a day. And we said, depending on, we're not done with the recruitment yet. It will happen this end of this month. So after that, we will also be able to form the event a little bit better. For instance, where to meet. Perhaps one of the municipalities will offer us a place to be. And then we would be able then to send out a date far in advance now, then in November. Hopefully that is enough time to plan everything. But then we will, for the next year, for example, have dates already after that first learning lab, so that everyone can gather their representatives and also form all the technicalities around the learning lab. A long answer here, but I wonder if that is the answer to your question.
Yeah, I think so. Yeah, I wondered whether it was a physical event. But so when you meet together for a half day or whatever, then you have a program of exercises, or is it focus groups, or what have you got in mind for how it's going to actually work in practice?
Literature that we have gathered around learning labs prefer to have an open question and then also informed by the literature of this question. So we're thinking about to write a text about social isolation and involuntary loneliness, for example, to give to the partaking municipalities and to inform the representatives so that we can talk about, or that we can have a joint picture of why we're there and why we are supposed to talk about a phenomenon as social isolation, so that everyone could be a little bit prepared, however, come with their own experiences and ideas of sharing then in this learning lab. So we will have an overarching question, but then also sub questions informed by these interviews that we are now doing with more on a structural level in the region, the civil society, and also in regions in how they go about preventing social isolation and involuntary loneliness.
So then there's some kind of report that's written, and that's given to the municipalities or somehow incorporated into policy. That's the idea. Yeah. Okay.
Yes. So the idea is this to get ideas, get support for their ideas, and a mutual exchange of ideas in this learning lab to take back to their own co-production team, and then also back again to the next learning lab, and then as we were talking about before, inject information from the citizen panel, where we will pinpoint question and get answers for what we're wondering as a research team about this.
Right.
Complex, but we will be happy to come back in a year's time or so, and we will be able to give you the exact way of doing a learning lab, or the
that'd be good. Yeah. Maria, do you use learning labs? Is that something that you also, or is it similar to something that you do within the communities?
When I was listening to Jenny, it really reminds me, I mean, like along the lines of the team under our national initiative, that is the Learning Health System team, that really capture what, for example, the PACE program that we train patients, and it's a patient-led program, right? Like they finish that report with recommendations for the healthcare system, and then these recommendations are embedded into the Learning Health System team that promotes these priorities or recommendations in general about something specific, and embed that into the healthcare system. And so they develop an initiative, then evaluate it, improve it, and it gets circular, and generate more data that informs different research projects and so on, like a very circular vision of how this. So in that sense, when I listened to Jenny, I thought, well, that resonates with this, but not specifically to, I really like the idea of the learning labs. Yeah.
Kiana, does that also fit with your experience? Have you got a sort of a learning lab process, or can you feed into that learning labs? Kiana?
I'm not sure what you're responding to, since we're involved in very different projects. So in the mapping review, I mean, there are some methods we come across how to do PPI or approaches, or whatever you want to call it. I mean, focus groups, of course, is is one way to do it. Then there's a term which has been coined experience-based co-design, and there is a toolkit for that, for example, for healthcare quality improvement, which I can also put the link in the chat if someone wants to have it. It was the Point of Care Foundation that created this toolkit. Then learning labs such as a method we didn't really come across, if I remember correctly, because I mean we looked at so many different articles which were all systematic reviews, so they were all already summarizing other papers. But I mean, another method for PPI is creating advisory groups, right, for healthcare facilities. And then this would be sort of on the consultation level where you're collecting information, but then the decision is still made by those people that organized the advisory group, right? It's so the decision-making process is sort of happening outside, and the influence on the decision-making is relatively low because it's not shared decision-making in a way. So it all comes to making decisions and how shared that decision-making is actually, right? So I mean, other methods we've come across, and that is then in a different context again, is like peer providers, peer support, right? Where, especially in mental health, there are even some people with a previous history of mental health problems actually get employed by a healthcare provider and then help supporting other people with mental problems or substance abuse, for example. So that is really, in a way, higher up on the ladder where you employ someone, and it's almost this or it's probably even eye-level conversations that then happen with other staff members that are also employed. So it really comes down to defining those levels, and I would much rather talk about roles than levels, because in some cases it does make sense to have just an advisory group that provides information and gives some insights that can then be used for the decision making. Because imagine if it was like the citizen control, the highest level on the ladder, like what would happen if we leave the control completely to the citizens, right? Somehow it comes down to making shared decisions, to co-producing, and to really identifying in what context what methods works best.
Now I see that we have run over a little bit, a couple of minutes, so apologizes for that, but it's been very interesting to listen to, very interesting talks and interesting questions. So John, we would like to thank everybody, the speakers, everybody who participated, right? And hope we will see you again. I think the conference we were talking about next year, but also in other talks maybe. So thank you very much. And I hope you all will have a very good afternoon, right, John? Or do we have something to add? Because I might miss something. Maybe we were told to.
No, I think you've covered it. I only to say to say thank you, and I think I've learned a great deal today. So actually, it's been very, very interesting.
Yes.
So, thank you.
Definitely. Yes, thank you very much. And Maria, I'm so glad the coffee is enough for you, since Maria is